Okay, so we're going to move on with our next session, which is focused on mental health in the metaverse. I can think of really no one better to kick us off than Brenda Wiederhold, who's been doing this work longer than most all of us, combined, really. She's been doing this work for an awfully long time. As a background in clinical psychology, has been using virtual reality for years and has been using it for a number of different conditions: anxiety, depression, PTSD. She's a co-founder of the Virtual Reality Medical Center. She's on staff at Scripps, I believe, is that right? And as I said, has an extensive wisdom and experience, and she's going to today share with us her experiences over the past decades using virtual reality and project the risks and benefits of mental health in the metaverse. And this is based upon, in part, a paper that she recently wrote that I saw and invited her to give a talk on this topic, because I can think of really nothing more relevant than this. So thank you for being with us today. I look forward to your comments.
Well, thank you for having me, Brennan. This is a great opportunity to be here, and it's a great opportunity to be anywhere in person now. I think I've only done 3 conferences since COVID kind of opened up, so it's very nice to see faces and talk to people. And I've actually met a couple people here that I had never met in person. I had spent hours and hours and hours on Zoom with them, but had never met them before, so very nice to be able to do this and to talk about my experiences since 1996 in the metaverse. And I want to start by acknowledging my best teachers, my patients. I'm licensed in both Europe and the US to treat patients, have lived 3 years in the Far East and 14 years in Europe, so have had the opportunity and the privilege of treating patients and training clinicians worldwide. I just recently, and anybody that knows me knows that I read the last page of a book first, so I don't like surprises. So spoiler alert, I just finished a 200-page report for the European Commission, which I consult for sometimes. And they wanted to know what the opportunities and challenges were as we move from virtual reality to XR health to the metaverse. And so spoke about those. And I will say, after completing the 200-page report, I'm optimistic, but I will say I'm cautiously optimistic. We do need some oversight. We can't have tech companies policing themselves always. I'm not a big government person, but I do think we have to have some rules in place. Things like social media influencers being therapists. There is a void right now. There aren't enough mental health providers. So we see other people giving advice, and they mean no harm most of the time, but they don't always have those answers that the patients are looking for, and they're very fragile sometimes when they're looking for those answers. So we want to give them the right advice. The National Health Services in the UK started over a decade ago looking at apps and validating apps. We've come online more recently in the US, as has the EU, but we need to do more with that. I think the FDA breakthrough program is excellent. I commend Applied VR for being the first VR app that made it through that program, and relatively unscathed, I will say. So bravo, I think we need more of that. And now I want to start with the history, because speaking to some of my colleagues here, we need to build upon the history, the successes, but also the failures of the past, so we could move forward to the present and the future in a more realistic way and a better way, taking those into account. I did my first randomized controlled clinical trial using virtual reality and biofeedback in 1996 to treat fear of flying. And I had 3 groups. One group got traditional therapy, one group got virtual reality, and one group got virtual reality plus biofeedback. So you see here, this is how oftentimes the patient comes in. Breathing very erratic, high heart rate, low heart rate variability, and this is after 2 sessions of training. So we want to train them to control that physiological response they've had in the presence of that phobic environment. Then we want to teach them those coping skills also for their cognition. So those automatic thoughts, help them to reframe those thoughts. And then we want to put them into the virtual reality environment and have them practice those skills, develop self-efficacy, self-confidence, and then translate that into the real world setting. Because it's good if you learn something in VR, but if you don't use that in the real world setting, it's not so great. So you see here a very clunky head mount. That's now in the National Library of Medicine. I'm very pleased to say that. So our patients used to get neck strain just from a 20-minute session. So now it's gone. Also, lots of wires. We don't need all those wires anymore. And the automation, I will say, it was okay. It worked, but we have much more realistic worlds now. So these were the results, 240 sessions. The group that got the virtual reality and biofeedback, all of them could fly without medication after 6 VR sessions. And after a 3-year follow-up, they could all still fly, so no relapse, no recidivism. The group that got just virtual reality, 80% could fly, and there was recidivism after 3 years. And the one person that did well in the imaginal therapy could still fly. So 15% of the population, 15%, can do well with imagination, but a lot of us don't have that ability. We need virtual reality to fill in the pieces. And we fill in the pieces differently. So your virtual reality will not be mine, even if you're shown the same thing. You fill in with your history, with your emotions, and you develop the content. We have, in the flying, I've had people that see flight attendants, they smell coffee, they're not having hallucinations, they're just filling in those pieces and creating their own reality. And that's where the emotional processing comes through, and that's where they're able to overcome that fear. The same thing in the people coming back from Fallujah. We have a heat lamp, we have a fan, and so they feel that hot wind blowing on them as their armored vehicle moves through the streets of Fallujah. They hear in the 3-dimensional sound those AK-47 rounds pinging on that armored vehicle. They're able to do that emotional processing at their individual pace. We don't want to re-traumatize them, so we're measuring their physiology in real time. We're moving them through that so they can have post-traumatic growth. And this environment over here on the right, you may say, well, that looks like a very benign environment. It's just a beach and a forest. Well, I had a patient from Jamaica. When I was seeing her in Brussels, I had a patient from Jamaica, and she came for stress management. I put her in what I thought was a relaxing environment, but it made her cry. And that's because she saw the groves of trees and said, this is Jamaica, and I haven't taken the time to go see my aging parents. I need to go see them. And so she started to cry. Now, the positive outcome was that she did go see her parents, but I thought I was putting her in a relaxation world, and I wasn't. Then I had a patient come from China, and I thought, uh-oh, what's going to happen now? And she saw a waterfall in the world and said, oh my gosh, this looks exactly like the waterfall in the south of China, where I always went on vacation. I can't wait to go there again. So positive, negative, you never quite know. What are we doing with anxiety? This is the one thing I started with and one of my specialties still. We're putting patients into the environment. We're having them confront what they're afraid of, change that physiological response, that cognitive response, having them confront those emotions, and then having them do behavioral change so that they can translate that and no longer have that fear or phobia in the real world setting. And when asked, there's been 2 studies, one in the mid-2000s, one more recently. They've asked people, which would you prefer, real life or virtual, if you had to confront something you were afraid of? And the majority of people say they would prefer to start with virtual reality. We've also looked at moving from a disease model, so treating people after they have a disorder, to moving to acute stress and acute disorders, to moving to prevention of disorders. And what we've found is when we can put a system, a virtual reality system, a treatment closer to the problem, so in this case in theater, we find an increase from an 80% success rate to an 86% success rate. We can also do stress management in theater so that they perhaps don't develop a disorder. And then we've also been able to do this with combat medics, emergency room physicians, and troops prior to deployment. In this case, it was with a group of Polish troops, our NATO coalition forces. We trained them in a virtual environment prior to deployment, and we were able to teach them those cognitive skills, those coping skills, those breathing skills, and I was very pleased because I am certified in biofeedback, and they said that learning the breathing was the one thing that made them the most in control when they went on deployment, and was very proud that we were able to, and asked and able to give our results to the European Parliament, the NATO headquarters, because it was the first deployment for the Polish troops. Nobody had been medevaced out because of medical or mental health problems, and there were no casualties on that deployment. We were then funded by the US Congress to look at prevention and prediction. So can we predict who is going to be at risk, most at risk for PTSD? We have found some predictors that can be trained, and so more effectively training prior to difficulties. We've also worked cross-culturally with our colleagues in Mexico, so being able to develop a surgical continuum of care. So sometimes patients are very anxious prior to surgery or medical procedures. So we want to start training them in the virtual reality prior to the day of surgery, then in the pre-op, then doing distraction during the treatment, and doing post-surgical in the post-op. So we want to give them the head mount immediately. And I'll tell you, we did this even before virtual reality. I'm a clinical health psychologist, and when I was in my training, my mom had to have surgery, and I said, you have to use this hypnotherapy. It's working well. I think it was the Symingtons at the time. And so I said, here's the tape, start practicing with it. The minute she got out of surgery, she asked her surgeon, she said, can I have my headset so I can listen to my tape? She took one extra strength Tylenol after a very serious surgery. So I don't think I could do it, but I was very proud of my mom. We've been using virtual reality for 25 years in the clinic, but as we move to XR and as we move to the metaverse, we want to start moving things far forward. So we want to move them into the patient's home or work setting. I was part of a 11 group program in Belgium, at my company in Belgium, and 6 countries, so we wanted a cross-cultural solution to stress management and burnout prevention in teachers and nurses. And this was in 2010, so long before they were stressed by COVID. But we designed, developed, and clinically validated virtual reality worlds. We did a 10-week program or 10-session program, 2 sessions a week for 5 weeks. We did full-on virtual reality and biofeedback in the clinic, and then we sent the patients home with non-immersive virtual reality and Mio Alpha watches, so they could control parts of the virtual environment with their heart rate. Very empowering. We were able to increase their coping skills, decrease their trait anxiety and their state anxiety. And trait anxiety is something we thought was not amenable to change or as amenable. But after those 10 sessions, we were able to change that trait anxiety for the positive. We've also worked quite a lot with our colleagues in China. And these are kitties. I'm not sure how to do this and not go forward. Oops. These kitties are doing their exercises. They've had eye disorders, and some of them have had surgery, don't want another surgery. Some of them have not had to have surgeries. So we teach them with the red-blue glasses. We send them home with a WeChat app, and they're able to continue their therapy at home. So we've put this in several eye clinics in China. We're now, for the last 3 years, working on macular degeneration and glaucoma in the adult population. we, as many people, had started to use virtual reality in the home settings with Samsung Gear VR and Androids prior to COVID. And then when COVID hit, we really accelerated this process. So we started shipping patients head mounts. Sometimes it was to use things on their own, so self-help, empowering the patients, letting them do that self-care. Other times it was me logging into my clinical portal and calling up different environments depending on what they needed help with. So treating them at home, using wireless biosensors so we could have that objective data. I also worked with my colleagues in Milan when COVID first started. We developed an audio-guided relaxation through a Japanese garden. It was on a fixed path. We had colleagues from 18 different countries translate that audio-guided relaxation. We put it freely available online. It's still freely available online. We validated it in Italy, Switzerland, Germany, and Spain, and just validated it in Iran. We have a 6th validation coming online in about a month. And this is on a compassion therapy model. So the protocol was more in line with COVID, and we have that online still if anyone wants to adapt it. But you can also just freely give this to your patients or your family members or use it yourself. I give it to all my patients that call in and want treatment even prior to them making their first appointment. Online worlds. This is one of the great game changers, I think, for the metaverse. A lot of worlds out there, we're able to get together, connect, able to go with our patients into different worlds and scenarios and treat them in real time. But we were doing this again back in the 90s. So these are floating heads. I would have patients come in with social phobia, and they could create their own avatar. A lot of them, it's very interesting. People with social phobia, oftentimes, they wanted the anonymity of being an animal first before they became a human avatar. And as they started to get better, they wanted to change their avatar and become a human. So just a very interesting insight I got from them. We now see that we have legs in some environments. So the avatars are getting better. I think this helps with the embodiment and the presence. But we were able to successfully use those worlds even in the 90s. Social media. When we first started, we didn't have Facebook, we didn't have Instagram, we didn't have TikTok, but we did have something called internet addiction already starting. So we were dealing with that, and now we're seeing, especially in our adolescent population, we're seeing increased suicide, increased depression. COVID kind of exacerbated this. So we're looking at how do we deal with that. We also see people, fear of missing out, comparing yourself to others, and getting that body image difficulty increasing. But we've also seen, during COVID especially, we were able to still meet with friends, meet with family, have Zoom tails instead of cocktails, do Zoom meetings, do our education online, do training programs online. So technology is not all bad. It's neutral. It's how we use it and how it is used that makes it positive or negative. It's also been really great. This is from the New York Times. These are 3 children whose worlds have been torn apart by war, 3 different countries, and you can walk through their eyes. You can go on their journey with them as they're displaced. And very powerful. This is a virtual environment, freely available. And I think having you develop that empathy, having these done in a very good way, a positive way, and being able to experience those and having that accessibility there is a very powerful thing. But I do like this quote, more is not better, only better is better. So, there's AI-controlled humanoid robots, there's ChatGPT, there's chatbots, there's all sorts of things out there, but unless they're done responsibly, ethically, and done well, they can do harm. So as we see all of these things converging, we see enhanced VR worlds, we see connected worlds that you can move across. We're seeing an increase in sexual harassment. There's better haptics, there's better tactile. You get harassed, you're really harassed, and that doesn't leave you when you leave the metaverse. Those feelings carry on, and that person can become fearful of being around people, being in certain situations in the real world setting. So we're often seeing that now. Another study that was just published a couple weeks ago by a group in Lebanon, 40% of adolescents in Lebanon during the COVID lockdowns were perpetrators of cyberbullying. So seeing an increase in that. Personally, I had my identity stolen during COVID. First, my medical records were all hacked. Then my IRS records were all hacked. And so when I tried to put my tax return online this year, the IRS said you can't do this online unless you answer these security questions. So the first question was, what type of planes do you own? So I couldn't answer that one. So the next question was, what countries are your planes in? Couldn't answer that one. The next one was, what model of planes are you having currently? And so I couldn't answer any of those. I have no planes, not that I know of. So I wish I knew where they were parked. But so I had to do my tax return in a paper copy, you know, like an old-fashioned paper copy this year. So if anybody does know who hacked me and where the planes are, I want them. So VR is a tool. It doesn't take the place of good clinical skills, good clinical judgment, and this even goes beyond clinical. We need to be training individuals to have that individual responsibility and give them the ability and the toolkit to not have those bad things happen to them as more and more of our lives are lived online. The nonprofit I founded in 2001 does do training programs. We've trained clinicians in 24 countries to use these tools more effectively because technology is a tool and we need to know how to use it properly. So we're doing that. We've worked with a group in the US to develop a master's training program in their master's level psychology, and with a group in Europe to also develop a new VR technology master's program so that we can start having people use these tools, learn about these tools, and implement them in their training programs. If you get out and you've used tools in your training program your whole career, you're going to get out and you're going to continue to use those and use them responsibly, hopefully. But if you don't know how to put them in the clinical pathway, if you don't know how to integrate those into the clinical care setting, you're not going to be as willing to do that when you get out and are, you know, just seeing patients. We started a journal published by Marianne Lieber in New York. It's a Medline Index journal 26 years ago. It's freely available in 106 developing countries, so we want to get the word out to everybody how technologies are changing positively and negatively, both individual behavior, interpersonal relationships, and our society as a whole. We also want to help people understand how to use tech as tools, so for training, education, therapy, and rehabilitation, as well as prevention. We have an upcoming issue. It will be published in April on virtual emotions. And I believe Joshua will be sending a code out. He's nodding his head yes. To everyone. You'll get, I think it's 30 days, but it may be 60 days free of access. So you can kind of check out the journal and see if there's anything there you're interested in. And if you're at a university, have your university subscribe to the journal. I've been editor-in-chief since 2009, just as a disclaimer. We also have a conference that was founded by the nonprofit that has an international advisory board that will be in Paris in July. And again, it's the same thing. We're looking at the impact of the technologies as well as how they're used as tools. So looking forward to connecting with everybody in person over the next 2 days. And thank you very much for this opportunity of speaking with you today.